And so I'm going to take time up front to greet him by name. I'm going to use his name often. I'm going to pet him. I'm going to talk to him, because I think a few minutes invested into the relationship up front is going to save me a lot of time down the road as I try to get him to communicate with me what's bothering him. The more he trusts me, the more accurately he's going to convey what's going on. He's going to be less likely to either, squeal or tense up at every one of my orthopedic maneuvers, or to play the role of the stoic and hide from me his responses to my manipulations. So I'm taking the time to say his name, give him commands. He's beginning to get used to the fact that he's supposed to respond to my commands. And then our first physical interactions are all very, very positive. I think we need to remember that, my lab coat and my diploma on the wall, those don't mean a whole lot to my patient. Instead, it's the smell of my hand, it's the feel of my touch, it's hearing me speak his name. Those things are much more meaningful to this patient, and really, I think, to most of our patients. Well, I don't know with old Cato here whether you've noticed, but so far he's much more comfortable outdoors than he is in, and that brings me to my next point. I think we should seek our patient's comfort before we seek our own. Ironically, in the end, I think we'll be more comfortable if we do that. For years, I would simply grab my patients and lift them onto the exam table and start manipulating away. And it's really no wonder that I had difficulty defining all but the most obvious causes of lamenesses when I did it this way. So now I'm going to try to consciously attempt to create an environment where my patient and I can relate to one another, in a setting that is comfortable to my patient, and that there's not too much to distract either of us. So in the end here, if with Cato he's most comfortable outdoors, then outdoors is where we'll do our exam. You may have noticed that thus far none of the exams have been filmed with the pet owner present. I don't mind if a pet owner is present during the exam, and as you know, many pet owners are going to wish to be present during the exam, and if that's the case, I will certainly honor their request. If, however, I sense that the owner's response to my manipulations is beginning to make the pet nervous, and this happens fairly frequently, once I've gained the trust of the owner, I will later request a second exam done outside of their presence. In the context of patient's comfort before my own, I think most patients are most comfortable with me starting the exam with them in a standing position. And I do prefer to start the exam that way with them in a symmetrical stance. In this way, I can kneel behind the patient and use both of my hands to simultaneously palpate the thoracic limbs, then along the sides of the trunk and the spine, and down both pelvic limbs. And the patient's becoming more comfortable with my touch all the time. In doing this as well, take for instance palpating the tarsi, I'm much more able to detect small amounts of swelling, effusion, or warmth around one of the tarsi. If I were to examine just one tarsus at a time and then later examine the contralateral tarsus, it's fairly likely that I wouldn't detect the subtle asymmetric findings that may be present. Now, as I transition from feeling for asymmetry to performing specific manipulations on each limb, if the animal is more comfortable laying in a recumbent position, then that's how we'll position the pet. And essentially, that's what happens here is this patient has been very content with a standing exam up to this point. But now it's my sense that there's some anxiety associated with it. I don't believe it's discomfort from the shoulder exam. And so again, patient comfort before my own. If this patient is going to be more comfortable in a laterally recumbent position, then let's complete our examination in that laterally recumbent position. My goal is for the patient to trust me enough that the patient again will say accurately, it hurts here, and I don't want to confuse anxiety for true physical discomfort. A similar question arises as to whether to perform the examination on an exam table versus on the floor. And I would say the majority of my patients are more comfortable on the floor than they are on the exam table. I will typically sit down on the floor as I learn their name and as I greet them, and you've seen that. As a result, I don't wear a lot of fancy clothes at work, but my patients don't seem to mind. As I'm petting them, I look for evidence that they're beginning to relax and trust me. And if they're comfortable on the floor, I'll gradually transition from petting to massage and then begin my palpation exam, somewhat as you've seen. Let's use our old friend Cato the Rottweiler as an example of all of this. First of all, notice I do have a muzzle on hand if I need it. However, he has, through kind of the transitions we've talked about, become a whole lot more comfortable to my handling. So I start out with what is petting, kind of massage down the sides of his trunk. I always have hands in contact with his skin. Subtle transition, seamless transition from petting to an exam, feeling for asymmetry in his pelvic limbs. Now I'll kind of work my way up and be petting for asymmetry in his thoracic limbs. And then we'll gradually transition from this to more specific orthopedic exam. And he is so comfortable with my touch at this point. About the only thing he's uncomfortable with is the fact there's a cameraman in the room. So now that he does trust me, I should be able to detect a response to painful stimuli, assuming that we're free of other distracting stimuli, such as slamming doors and such. And you notice here, see there, he looks outside, and that was in response to a noise outside of the exam room.
Good boy.
I should point out that while I am an advocate of not overdoing patient restraint, because I do want to see their response, we obviously do have to protect ourselves. And if the patient gives me any clues that his response may put me in danger, then I need to provide enough restraint to protect myself. Now, I'm very pleased with how successful we've been at putting Cato at ease for his exam. Nonetheless, I am taking some precautions with him. Normally for a thoracic limb exam in the standing patient, I'll be almost face to face with the animal so that I can see subtle changes in the expression of their eyes, etc. With a male Rottweiler who has expressed some anxiety over my dominance upon him, I'm not going to do that. And so I'm standing in a less aggressive position at his side. Even so, if I have any concerns whatsoever, because I am in a bit of a vulnerable position, I'll either put a muzzle on him or I'll have an assistant hold a slightly tensioned leash so that he's less likely to be able to swing around and take a bite at me. Well, I hope I've been able to share with you a few tips that you'll find useful on the art of the meaningful orthopedic exam. The premise of which is our patients will do their very best to tell us where they hurt if we can gain their trust. How? Well, we watch them when they don't know that we're looking. We strive to be their friend before we try to be their doctor. We seek their comfort before we seek our own. And we use lots of hands-on because we recognize that the exam doesn't need to be a lot different from the petting they receive from one of their trusted friends. Hi, today we're going to observe a 10-year-old neutered male border collie with very subtle lameness that is due to multiple abnormalities on the orthopedic exam. I think this patient will serve as a very good model for the challenge of detecting and localizing canine lameness. The goals of the lameness exam are first to classify the patient as sound, lame due to orthopedic causes, or ataxic/paretic due to neurologic causes. Another purpose of the lameness exam is to localize the lameness to the affected limb or limbs, and ultimately to grade the lameness. We typically use a 0 through 5 grading scale, but many lameness scales have been described. One of my tips is to observe the patient when they don't know that you're looking. This is a chance to see the animal as they move naturally about their environment, the way they shift their weight as they sit. Are they willing to rise normally? Are they willing to jump up on a chair or a bench? Are they even willing to put their paws up on the counter as they surf for treats? All of these give you clues as to what may be comfortable and what is not uncomfortable. We didn't have that opportunity for the filming of this patient, so the first step today is to acclimate the patient to the handler and to their environment. We're trying to get the patient to the point that they can move comfortably about the room with a symmetrical posture where they're not pulling on the leash, etc. I observe for symmetry of their gait. That is in regard to their stride length, their stride duration, and the way their limb moves through space. Are they circumducting their limb? Are they abducting or adducting their limb? Thoracic limb lameness is best observed as the animal is moving towards you. Look for a head bob or a head rise and try to get in sync with the dog's gait by saying up every time you see the animal's head rise. You can see how much easier it is to observe the patient when slow motion video is used, and this is available to you even on your smartphone. That said, even with slow motion video, this patient does not have a pronounced head bob. As the animal moves away from you, you can observe the pelvic limb gait. Once again, observing for stride length, stride duration, any circumduction to the gait, as we've described before. Additionally, look for a hip hike or a pelvic lift. Just as the head may rise to off-weight a painful thoracic limb, the hip may rise to off-weight a painful pelvic limb. Additionally, there can be a pronounced hip sway if there is discomfort within the region of the hips. For example, this dog seems to have a slightly pronounced lateral movement of the pelvis, the so-called hip sway. So I will be interested to see if there is any discomfort that can be localized to the region of the hips, the iliopsoas muscle tendon unit, or the lower lumbar spine. It is also helpful to have the animal move from side to side in front of the observer. This gives you a chance to watch each limb as it independently moves through space. It's a good chance to observe things like stride length. For instance, looking at the stride length of the pelvic limb may give us some clues, once again, regarding hip or iliopsoas discomfort. Dogs with discomfort in this region will oftentimes have a reduced stride length. Since dogs increase their stride length as they run, it can be helpful in dogs that have very subtle changes to their stride length to actually observe them as they run. Once again, using slow motion video will help to capture some of the observations that may be difficult to see because of the rapid movement of the patient. Observe the animal closely for lameness. Do you see a head lift? Do you see a pelvic lift? Do you see changes in stride length? Well, the good news is I don't believe this dog has obvious gait abnormalities that have been displayed thus far. There may be a very subtle decrease in hip extension during the terminal phases of the stance phase, that is, at the point of paw push-off, if you will. I like to observe the animal as they sit. Normally, an animal should be able to sit squarely. This involves maximal flexion of the stifles as well as of the tarsi. Reluctance to fully flex the stifles and tarsi can be indicative of pathology in either of those joints or perhaps both. Another trick that will help you detect subtle lameness is to observe the patient on stairs. Their weight is shifted to their pelvic limbs as they go up the stairs, and conversely their weight is shifted to their thoracic limbs as they descend stairs. This patient seems to have very little difficulty with the descent of stairs. However, when he's asked to go upstairs, he sometimes seems to be reluctant to push off, particularly with his right pelvic limb. My hands-on exam begins with the patient in a symmetrical stance, what I call my spandex exam, and this can be either at the beginning or at the conclusion of my general physical exam. But I'm running my hand symmetrically over the entire patient. I almost imagine that I've got eyes in my fingertips. I'm trying to detect any asymmetry, whether it's asymmetry in lymph nodes, whether it's asymmetry in muscle mass, joint effusion, tissue warmth. It really doesn't matter, but this is a perfect chance to pick up asymmetry. Now you may notice that I'm actually palpating very specific landmarks, and we're going to go through those in more detail as we talk about the individual limb exams. But here I'm working down the anabrachium, feeling the carpi for effusion, and then for swelling in the digits. Musculature of the thighs. Now I'm feeling the contours of the stifle, which we'll discuss, the Achilles mechanism, effusion in the tarsi and now down in the digits. Here are the popliteal lymph nodes. I'm going to palpate the patient's abdomen, so this can be that portion of the exam. And I'm going to take this opportunity to detect any spinal discomfort. And this dog does seem to be a little bit sensitive in his mid-lumbar spine and occasionally in his lower lumbar spine. I will then gently, but hopefully fully, move his tail into dorsiflexion, left and right flexion, and I'll do something similar with his head. Here, try to move his head to the right, and he's moving very freely. I'll move his head to the left, again moving very freely and without discomfort, all the way up and all the way down. Now we'll evaluate the individual limbs, and we'll start with the pelvic limbs. This can be done with the patient standing or recumbent. Really, it's a matter of how they're most comfortable. Most instances, I work from distal to proximal, so I'll begin by investigating the pads and the interdigital areas, again looking for trauma, foreign bodies, and as I evaluate each of the digits, I'll also feel for swelling and discomfort. And as you know, many dogs are going to be sensitive to digital palpation, but this is particularly problematic when it's more extreme in one digit than the others and is associated with swelling or warmth. Now I'm feeling the metatarsophalangeal joints and their associated sesamoids and running those joints through a full range of motion. I'll palpate the soft tissues and bones of the metatarsus, and then I'll work my way up to the tarsus. So I want to evaluate the tarsus for full extension and full flexion. Here you can place the dorsum of his paw really up next to his tibia. It's got very good range of motion. And out into nearly 180 degrees of extension. Then I will go ahead and test him for instability in varus and valgus with the tarsus fully extended. That tests the long components. And then I'll do the same with the tarsus in flexion, and that tests the short components of the collateral ligaments. I'll feel for joint effusion, and typically I'm feeling in the region between the malleoli, in this case the lateral malleolus, and the tubercalcis. And that region between those is where I typically can feel effusion. Here I'm stabilizing the calcaneus, and I'm feeling for instability in the proximal intertarsal joint, or the calcaneochordal joint. I can feel the Achilles mechanism as it inserts on the tubercalcis, and normally I can feel 2 of the 5 components of that Achilles mechanism. Now I'm feeling the soft tissues and bone of the tibia, feeling for discomfort, swelling, etc. Evaluating the stifle in full flexion, as well as in extension. And even in the normal healthy stifle, on occasion, forceful extension of the knee will elicit some discomfort. While the knee is extended, I can test the collaterals medially and laterally. Next, I can perform the tibial compression test, or what some people call tibial thrust, as a test for cranial cruciate ligament incompetence. I'll place my thumb behind the lateral fibula and my finger on the tibial tuberosity, and I'll squeeze those together. I call these my X-cap fingers because they course along the same pathway as an extracapsular suture. As I squeeze them together, I then flex the tarsus while holding the stifle in a standing angle. This generates tension within the gastrocnemius mechanism, and in the cruciate ligament incompetent knee, you will feel the X-cap sutures stretch out, that is, the tibia displacing forward. I sometimes find that the drawer sign is easier to elicit with the dog in lateral recumbency, so I think that's what we'll do today. So let's evaluate now the bone and soft tissues of the thigh. So here, palpating up the femur, palpating the hamstring muscle group, now going to range of motion of the hip, so we can fully flex the hip. The femur is essentially parallel to the lumbar spine, and gradually I can extend the hip, although the dog does seem a bit reluctant to that. Now that can be behavioral in a dog who's a bit tense, but also can be a sign of discomfort, and so that's going to take some discernment on your part. So that said, I'm a little bit suspicious of hip discomfort, but certainly it could be in the low lumbar spine or it could be in the iliopsoas region, so we'll keep going. Here I'm abducting the hip, and the dog seems, again, a little bit uptight about that, but is certainly permissible a full hip abduction. So to evaluate the iliopsoas muscle group, we will combine hip extension with internal rotation, and that elicits discomfort. And so there, I'm highly suspicious that he still has some iliopsoas discomfort. The iliopsoas runs along the ventral surface of the lumbar spine and inserts on the lesser trochanter on the medial side of the proximal femur. So by combining hip extension with internal rotation, I was putting that iliopsoas muscle group under tension. Here, as I palpate the insertion of the iliopsoas, I can actually detect some spasm, and again, he seems a little bit uncomfortable to this maneuver. I also performed a rectal exam, although that doesn't actually make great video, but what I was looking for was discomfort as I swept my finger along the brim of his pubis. And lo and behold, what I did discover was that yes, he did have discomfort, more so on the right pubic rim than on the left pubic rim, again consistent with iliopsoas discomfort. Then let's go ahead and move to the recumbent exam. I don't always do both a standing exam and a recumbent exam, but I think it's worthwhile to show you each. So we'll begin once again by examining the pads and between the pads. Then I'll palpate the digits, especially for thickening. If there is thickening or discomfort, it's worth palpating for instability. Next, I'll palpate for swelling and discomfort in the metatarsophalangeal joints and their associated sesamoids. Then I'll palpate up the metatarsal bones. Then I'll evaluate for tarsal flexion as well as extension. We'll feel for a fusion between the lateral malleolus and the tubercalcis. Then we'll test for collateral ligament instability with the tarsus in extension, testing the long components. And then we'll test again for varus and valgus instability with the tarsus flexed. And this is testing the short components of the medial and lateral collaterals. Then I'll palpate the Achilles mechanism insertion on the tubercalcis, and it has no swelling, no discomfort, and I can actually feel two of the components of the Achilles tendon. Then we'll palpate the tibia and the surrounding soft tissues up to the level of the stifle. The stifle will test for full flexion as well as full extension. We can test for collateral ligament instability with the stifle in extension, so we can apply a valgus stress to test the medial collateral ligament, and we can apply a varus stress to evaluate the lateral collateral ligament. And now we'll evaluate for cruciate ligament instability. To do that, we'll use the tibial compression test to evaluate for cranial tibial thrust instability. To do so, I'll place my thumb behind the lateral fibula and my finger on the tibial tuberosity. And these are my X-cap fingers. And I'll squeeze them together like an X-cap suture. And with the stifle held in a standing angle, I will flex the tarsus to create tension within the gastrocnemius mechanism, which will compress the sloped surface of the tibia against the femoral condyles. And in the cruciate deficient stifle, you will feel cranial tibial displacement. We can also do the drawer test. To grasp the femur with my proximal hand, I will place my thumb behind the lateral fibula and my finger on the patella. To grasp the tibia with my distal hand, I will place my thumb on the fibular head, and I'll try to roll the fibular nerve off of the fibular head, and my finger will be placed on the tib tube. And I will stabilize the femur with my left hand while I attempt to create a drawer motion with my right hand. And this should be done in extension as well as in flexion. On the inset, you see a cranial cruciate deficient knee. Then we will palpate up the femur, and we'll feel the soft tissues of the thigh, including the quadriceps group in front, the hamstring group in back. And then we'll assess passive range of motion, and I usually start with hip flexion. The femur is now parallel to the spine, and we'll go slowly into hip extension. Now, anxiety can limit the amount of extension, so go nice and slow. And if there is some resistance to hip extension, as we're encountering, that could be hip joint, could be lower back, could be iliopsoas, or some combination thereof. Next, we'll abduct the hip, and oftentimes dogs with hip joint discomfort will resist this, as he is. So he may well have some hip joint discomfort. And we previously evaluated his iliopsoas by combining hip extension with internal rotation and found that to be quite uncomfortable. So I don't think we need to repeat that. To evaluate for the possibility of a traumatic hip luxation, we can use the triangle test, which involves palpable identification of the ischiatic tuberosity, the greater trochanter, and the dorsal iliac spine. And notice that these form a shallow triangle in the normal hip. When there is a dorsal luxation, these 3 points will often form a line. The thumb pinch test can also be used to evaluate for traumatic hip luxation. Start by palpating the greater trochanter, palpate the ischiatic tuberosity, and place your thumb between them. In the normal hip, your thumb will be pinched between the greater trochanter and the ischiatic tuberosity as the hip is externally rotated. And that's what I'm feeling here, because this dog, of course, does not have a traumatic luxation. Neither the thumb pinch test nor the triangle test, which are used to detect traumatic hip luxation, should be confused with the Ortolani maneuver. Now, the Ortolani test is used to evaluate for hip joint laxity. To perform the Ortolani maneuver in the laterally recumbent patient, I will place my hand along the dorsum of the pelvis. The hip is held in a standing angle. Then I will create a force directed up the axis of the femur, and if there is laxity in the hip, it may subluxate, but I don't always feel that at this stage of the maneuver. But then I will gradually abduct the hip, and feel for reduction of the femoral head. Then I slowly adduct the hip until the femur is back in the normal position, and I feel for subluxation as I do so. Now, for this elderly patient with hip pain, I don't think we need to repeat that particular maneuver. If there were associated discomfort, obviously this maneuver could be performed with sedation if it were indicated. So now let's move on to evaluation of his thoracic limbs, and this can be done with the patient standing or recumbent. Depending upon the temperament of the patient,
Okay, anyone have any questions for the hind limb? Hello, can you hear me?
Yes, doctor, we can hear you.
Yeah, because the time for this Zoom is going to finish, I managed to establish the one that using the UPM account, see whether we can use this Zoom or not. Or maybe longer time, I don't know. Okay, is there any questions that you want to ask? Okay, for the limb, right? For the lameness in the small animal, one thing you must make sure visual in the distance first. Okay, from the distance you look at the animal first, how they move, how they run, how they go up to the staircase, and then how they come down. Okay, and then only you proceed to the physical examination. Okay, and then the environment must be comfortable to the animals, because we saw a lot of animals, right? When they come to the vet hospital, if let's say there's a lot of dog barking, cat meowing, they will refuse to move. They will just hide at the one side, or they will show the aggressiveness. Okay, so when they need to move under the comfortable environment. Okay, sometimes I even bring them to the back so that they can move at the large animal alley there. Okay, so it is up to you, where do you work next time. Okay, second thing is during manipulation, one thing Professor Ross just now, he showed that approach, and then without the presence of the owner, and then it's like really face to face. That is the dogs that they actually went for the class. Okay, the training behavioral class, the training class. Okay, Malaysian dog, I can tell you 8 out of 10, right? They can be very aggressive, especially when they have pain. Okay, so what I do normally, if the dog is very suspicious, might bite, I will just put on the muzzle. Okay, I know it's not comfortable for the dog, but you still need to protect yourself. And then sometimes I even ask the owner to comfort the dog in front of the dog, hold the head. Okay, when I palpate. For the dog, we examine the animal, starting from the non-painful one. Then after that, only you do the painful one. But for cat, immediately you have to examine the painful one first. Okay, because you won't have any chance. Okay, cat, they will become very aggressive. Okay, you only have very little amount of time to do your examination. Okay, and then to do the physical examination, we start from the toe first, from distal to up to proximal. Okay, you need to